Welcome back again. The Asian respected the next generation leaders actually from 6 countries. If everybody could just afford to, could avail themselves to attend this now casual the lectures. Last semester, I could invite. It was a really luck to invite Professor Edmund Kim based on his almost 30 or 40 years of experience and his up-to-date knowledge about the progress of the nuclear medicine. He could just convey his wise understanding to the next generation of the Asian the nuclear medicine physicians. And from this semester, if feasible, we are going to come back to the reality. As you well know, Korea was invisible from the community of the nuclear medicine, even though we established the nuclear medicine now 60 years ago. However, it was a kind of a sub-discipline of internal medicine, interestingly. And in some other institutions, radiology has spun off nuclear medicine. So if I'm going to remind you the past of our country for nuclear medicine, it was just kind of meager and invisible. And sometimes when I started nuclear medicine 1990, 30 years ago, it was frustrating. So you might just expect frustrating, but interestingly, we were not frustrated. We were at the bottom. So what you do is just kind of a jumping from the abyss or bottom. So it means that it is kind of infinite amount of progress, and that infinite amount of progress had been had taken place in this country, and now we are taking care of even the future of the nuclear medicine. So if I disclose my bias that the future of nuclear medicine is not depend upon, it does not depend upon the past success, which has caused a extreme polarization or bipolarization, meaning from the standpoint of WHO, until recently, the nuclear medicine is the kind of a position of the richest people, and with their catchphrase of the leave no one behind, meaning leave no one behind in terms of the vaccination, or leave no one behind in terms of the mother-child care, without any mortality, unnecessary mortality, or even the non-communicable disease. So, but interestingly, nuclear medicine was considered tertiary care, and now they recognize the nuclear medicine is one of the essential the ones. So I can just say that proudly, if you are interested in the future of nuclear medicine and your career, then you might just kind of casually, while just doing your business, meaning the patient care and reading the images and then taking care of the people after therapy. So there was my original intention that once we start this kind of lecture series, we are going to start Professor Edmund Kim's and one of the global leaders who had made a nuclear medicine of the United States, originally from Korea. However, he stayed there more than 40 years as a professor, and he is also the founding member of the American Society of Magnetic Resonance Imaging, MRI. So, he's quite a well-known the radiologist. So, if I just say about the history of nuclear medicine, our country's real history of nuclear medicine has started 1996, 25 years ago, when the Professor Myung-chul, who is now a retired and honorary professor of our department, he could successfully persuade everybody alongside the medicine and within and without medical field that the nuclear medicine become the boardmanship. What I'm saying is just we have 26 board personship in this country, and nuclear medicine and family medicine and emergency medicine, and also occupational and the environmental medicine, the 4 disciplines that become the legal one. So since 25 years ago, we could just kind of produce or generate the next generation leaders. And now you are going to listen to those next generation leaders who measured not internal medicine, not the radiology. From the beginning, they have chosen nuclear medicine as an essential medicine discipline, and now came to be the promising the next generation leaders of this country as a professors majored in nuclear medicine. And today's the invited the professor is a little bit more unique in his career. He had finished the nuclear medicine board personship and also a PhD, and then came to the United States and University of Wisconsin and stayed 2 years there, and then had published a lot in the nanomedicine field. And nanomedicine is just kind of, they are going to, if successful, broaden our armamentarium of radiopharmaceutical, which is also called radio nanomedicine. And then he's now the professor in a department of applied bioengineering. And sooner or later, he's going to join our hospital now. And also, let me just tell you that he is the key editor and author of a Springer book of the famous SPECT-CT, PET-CT, and PET-MRI. So I'm very happy to invite him, and he sincerely and he willingly agreed to give us a lecture, though his major interest recently is basic and engineering research to broaden the nuclear medicine. And you might just ask any question to him regarding lung cancer and breast cancer, though his discipline is much more expensive. So I asked 2 minutes, but I consumed 8 minutes, and he's going to lead this lecture regarding that. So please kind of welcome Professor Im. Right.
Much for the kind introduction and inviting me to this lecture, Professor Dong-Soo Lee, and thank you all for joining today here. I'm looking at like 40 people here. So as he mentioned, I actually edited the PET-CT, PET-MR atlas a few years ago. But currently I'm not in the reading room right now. I'm sitting at the office doing some basic research now. So I don't think I'm the best person to explain this correlative imaging in lung cancer, but I have some experience, and I did some lecture using this material. So hope you enjoy today, and let me know if you have any question or comments during the lecture. Do you hear well?
Yes, good.
Okay.
Very good.
All right. So I'm going to talk about the anatomy and structure in the lung and lung cancer for staging and role of FDG PET-CT scans and some case reviews. So as you all know, that lung consists of the large airways and parenchyma, and right lung has 3 lobes, upper, middle, lower lobe, and left lung has 2 lobes, upper and lower lobes. And when you look at the airway, you can start from the trachea, and it divides into main bronchus, and main bronchus divides into lobar bronchus. The lobar bronchus divide into segmental bronchus. And those division goes on, and it became bronchial when the cartilage is not present in the airway. We call it bronchial. And then bronchioles divided into terminal bronchioles, and finally it becomes respiratory bronchioles that meets the acinus that can do the gas exchange. So you can see it this way as well. If you call the airway generation 0 for trachea, then main bronchus will be generation 1, and lobar bronchus will be generation 2, and goes on and up until 7th generation. And normally in 8th generation, it doesn't have any cartilage, so we call it bronchioles, and it goes on to 19, and then it comes alveolar duct that meets alveolus. So to the physiological view, this structure can do both things. One will be efficient conduction of the air to the final destination, and also it can give us a very large cross-sectional area for respiration. However, those small structures cannot be seen on our CT or PET-CT scans. For the airways, we can see on the CT scans up until let's say segmental bronchus, and next generation, maybe around 4th or 5th generation, we can see those bronchus. And there are names for all of these bronchus. However, we cannot memorize all of this, but I think it's good to hear some time to time and then look for it. So I'm going to explain those bronchus. So firstly, it can start from trachea and right main bronchus. And right main bronchus has divided into right upper lobar bronchus, and right upper lobar bronchus is divided into 3 segmental bronchus. After division of right upper lobar bronchus, it becomes bronchus intermedius. And bronchus intermedius divided into right middle lobar bronchus and right lower lobar bronchus. For the right middle lobar bronchus, it has 2 segmental bronchus, and for the right lower lobar bronchus, it has 5 segmental bronchus. So one is divided very early. It's for superior segment, and there are 4 basal segments, segmental bronchus. And when we move to the left main bronchus, you can see the first left upper lobar bronchus here. And left upper lobar bronchus has two segmental bronchus. Actually, it's 4. 2 goes up and 4 goes laterally and anteriorly. It's called lingular segments. So it's a counterpart for the right middle lobe. And right lower lobar bronchus has about 4 to 5 segmental bronchus, which are similar with the right lower bronchus. And although we cannot see the functional unit in the CT scans, but it's always good to know what's in there. So as you all know, the alveolus is the smallest gas exchange unit. It's like a sac surrounded by the pneumocyte type 1 and 2 and some and then it's surrounded by capillary as well, so that gas exchange is very efficient in the alveolus. And those alveolus and the sac and the alveolar duct, which is the last part of the airway, with this combination, we call this combination as a primary pulmonary lobule. And then with the terminal bronchiole with it, and we call it acinus. So you can see the acinus here. It's kind of very small unit, which is bigger than alveolus, but very small unit for the gas exchange. And then with 30 to 50 primary pulmonary lobule, they combined as a secondary pulmonary lobule. So, and it's surrounded by interlobular septum. So inter means between, so interlobular septum is surrounding the secondary pulmonary lobule. And though in these septa, pulmonary vein and lymphatics are running through this septum. So in the CT scan, we cannot see all of this structure actually, because it's too tiny. But in the disease state, sometimes if these interlobular septum is thickened, then we can see the interlobular septum. So we call it in the CT scan interlobular septal thickening. So normally it doesn't, it cannot be seen on the CT scan, but we can see it if there's something wrong. So that's why I explain all of these. And this is just the same image to show the secondary pulmonary lobule. So you can see the interlobular septum like this. So this is really a terminal location of the lung. So these are all very small, but can be seen on the disease states. So let's look at the CT scan here. So this is a normal CT scan. In soft tissue window, it is very nice to see the normal structure of especially the vascular structure. So I'm going to explain the vasculature in the lung. So there are a lot of nomenclature here, but basically what I did for the atlas was making these all of these pointings and naming of the structures. So in this scan, to explain the vasculature, I'm going to start from the left ventricle because we all know where blood goes. So if you start from this left ventricle, you can see the blood goes to the ascending aorta. You can see the ascending aorta, and ascending aorta ascends and makes aortic arch and descends, and descending aorta goes down all the way down to the diaphragm and became abdominal aorta. You may all know all of these. And then if you go up, then from aortic arch, you can see the for the left side, common carotid artery and subclavian artery divided in directly from the aortic arch. And then for the right side, it's a brachiocephalic trunk, which will be divided into common carotid artery and subclavian artery. And common carotid artery, as you all know, goes up to the neck and brain, and then subclavian artery will intersect to the arm area below the clavicle. You can see the intersecting subclavian artery here. Pardon me? Is there any question at this point? I heard someone speaking, but I cannot hear you clearly. But
Lady someone is not intentionally the unmute his or her audio. So in that case, Mr. Kim Dong-bin would just kind of turn off, and except for the presenter. So that was the case, as often the case. Okay. And let me just tell you, Professor Im, interestingly, there are some scratches on your slide, even though you do not recognize. So it happened sometimes kind of a zoom error. So your cursor is moving, sometimes it is drawing. So interestingly, it's
okay. Maybe I can start the PowerPoint again to remove these things.
Yeah, so you see too. Okay, so then you see the scratch marks, then you just log out and log in again. Not log out, just PowerPoint using. Would it be PowerPoint problem or?
I think it's because of the.
It might be not PowerPoint problem. It's we suspect that it's a problem of Zoom. Zoom is giving. 김동빈 씨 혹시 이거 지금 괜찮네요. Okay, it's good.
Yeah, I think I should renew the this thing. Right. Okay. So now it's okay, I think. I finished actually the systemic circulation part, and after it goes to the system and it goes to capillary, it comes to the vein, larger vein, and even the largest vein from the bottom of our body system. So you can see the inferior vena cava in the abdomen, and it's merged with the hepatic vein lastly, and it goes up to merged to right atrium, you can see here. And from the superior part of our body, the subclavian vein and the jugular vein merged to be brachiocephalic vein right side, and you can see the brachiocephalic vein left side here. And this left brachiocephalic vein is draining blood from the left subclavian vein and the jugular vein up from the top of our body. And this left side brachiocephalic vein intersect to merge with the brachiocephalic vein right side. And then it becomes superior vena cava. And also, its important structure here is named azygos vein. Azygos vein is draining blood from the posterior part of the thorax, and this joined with SVC. This is important because it's a landmark for the lymph node station I'm going to talk about later. And then SVC goes down and enters into right atrium. And from right atrium, it's natural to connect it to right ventricle. And right ventricle is responsible for pulmonary circulation. So this goes up and it gives blood to a pulmonary system from pulmonary trunk, and pulmonary trunk divided into right pulmonary artery and then left pulmonary artery. And though the left pulmonary artery is also important because it's going to be a very important landmark for the lymph node station. And then it goes to the lungs and lung arteries and capillary and vein, and the vein merged into 4 different pulmonary veins. So 2 in the right side and 2 in the left side. So when you look at the right side, you can see the right superior pulmonary vein is connected to a left atrium, and the lower side, you can see the left right inferior pulmonary vein connected to a left atrium. And also, you can see the left superior pulmonary vein is connected to left atrium, and also the inferior pulmonary vein connected to left atrium. And then this left atrium goes connected to left ventricle through the mitral valve, and it starts all over again. So these are the vasculature structure in the thorax, and in the soft tissue view, we have to look at these other soft tissue structures, like importantly this adrenal gland, whether if there's nodules or thickening, it looks very nicely thin structure, and right side as well. Okay. And I think that's all we need to know for this in this CT scan. And we can move on to the lung window. So in the lung window, we can clearly see the airway and the lung parenchyma. We have to look at the lung parenchyma first. You can see the lung parenchyma nicely in this lung window. As I mentioned before, it is hard to recognize the primary or secondary pulmonary lobule in this lung area because they are too small to see. But when the interlobular septum thickening happened, then we can see these lining at the very periphery of the lung as well. So right, but in this scan, we don't see anything like that, and we don't see any nodules as well on the right side and left side as well. We don't see any warning sign here. So we can look at the airway now. So it starts from trachea, as you all know, and beside that, I can see small air sign in the esophagus, and trachea divided into a main bronchus, right side and left side here. And from right side bronchus, firstly it divided into right upper lobar bronchus. Upper lobar bronchus has these three three segmental bronchus. So this one is already divided to the superior part, and then anterior posterior segmental bronchus it is divided from the right upper lobar bronchus. And then after division of right upper lobar bronchus, it comes bronchus intermedius, and then it's divided into right middle lobar bronchus and right lower lobar bronchus. In the very early part of the right lower lobar bronchus, there is one superior segmental bronchus divided first, and then uh, from the right middle lobar bronchus, it has two segmental bronchus, medial and lateral. So medial goes to medial side and lateral side, and the remaining right lower lobar bronchus divided into four different basal segmental bronchus. So it's anterobasal and medial basal and lateral basal and posterior basal. So there are four basal segmental bronchus from right lower lobar bronchus. And then you can see the fissures as well. It is very important to know where the primary tumor is, so, and the metastatic nodule is. So it's really important to know where the fissure is. So you can see the kind of, it's not very clear here, but you can see a blurring in the lung field indicating it's a major or oblique fissure. So anterior part will be right upper lobe, and posterior part from here will be right lower lobe. So it goes up and here. So from here, there's a still major fissure to divide the right middle lobe and right lower lobe. And then that major fissure goes down to here as well. So in front of this is right middle lobe, and posterior of that fissure will be right lower lobe. And then there is another fissure that divide right upper lobe and right middle lobe, which is not clearly seen because it's run horizontally. So, but you can faintly seeing the minor fissure here. So above this minor fissure, it's right upper lobe, but below that, it's right middle lobe. So that's what's on the right lung. And for the left lung, it's quite similar. So you can see the main bronchus left side, and then right upper lower bronchus. It has four branch from right upper lower bronchus. One goes up and to be anterior segmental bronchus and apical posterior segmental bronchus, and two goes down are lingular segmental bronchus, inferior and superior. So as I told you, this is counterpart of right middle lobe. And then after that, it become left lower lobar bronchus, and early in early part of left lower bronchus, there is a superior segmental bronchus goes up to upper part of the left lower lobe, and then also there are 3 to 4 basal segmental bronchus like this. So these divided into several segmental bronchus. And also you can see the major fissure dividing right upper lobe and right lower lobe. So you can see a faint line here. It starts and goes down obliquely. You can see you can trace the fissure as obliquely goes down. So it's much easier than right lung because it has only one fissure and two lobes. Okay, so that's normal structures for the lung. So I explained the vascular structures and also the airway as well. So I think it's not practical to memorize all of that, but it's always good to look back with this PowerPoint. I think it will be uploaded. It's already uploaded, I guess. So feel free to use it. And then lymph node station. Lymph node station, as a nuclear medicine physician, it's really important to know these lymph node station because FDG PET CT scan is very nice for NM staging in lung cancer. So reporting of the right lymph node station will be very helpful for our colleagues. So, and this station has not been changed for, I guess, at least 10 years. So I'm using this reference, which was published in 2009. And when you look at it, number one, these are low cervical, supraclavicular, and sternal notch nodes. And these are all N3 nodes. If it's ipsilateral or contralateral, it's all N3 nodes. So it's important to know where it is and if there is or not. And then it enters into mediastinum. In upper part of mediastinum, there are two R and L, paratracheal, and 3A and 3P. You can see here, 3A is prevascular, which is an anterior part of the major vessels, and 3P will be the posterior part of trachea. In 4R, which is lower paratracheal, and 5 and 6 is around aortic arch, and 5 is below the aortic arch, and then 6 is adjacent to aortic arch. And 7, so inferior mediastinal nodes, includes subcarinal after below the carina, and then 8 is below the 7th station, and 9 is around pulmonary ligament here. And again, 10 and 11, 10 to 14 nodes are all the N1 nodes if it is at the same side of with the primary tumor. So number 10 is hilar around the main right or left bronchus. And then 11 is after division of the lobar bronchus. And then 12 around lobar bronchus. And these separation of, I think separation between 10 to like 14 is not too important because these are all N1 nodes. So separation between the mediastinal, like 4 and 10 is super important because it's a division of N1 and N2. And number 1 and 2 is also very important because it divides the N2 and N3 nodes. So I'm going to talk about that in detail in the next slides. So this is the same figure, so you can use it for your convenience. And let's look at those lymph node station in the CT scans. I wrote the upper and lower margin with the white letter here, and then yellow letter indicates the name of the lymph node station. So station number 1, upper margin is cricoid cartilage, you can see here. And then lower margin is clavicle and manubrium. So laterally it's clavicle, and in the middle part it's upper margin of manubrium is the lower margin of station 1 lymph node. So these are the station 1R and 1L area. And when it goes down, it can be same section with the 3P, but division between 1 and 3 is not too difficult because 3Ps are just posterior. Posterior margin of trachea will be the cutoff point. And one other important thing for number 1 and number 1R and L, division of R and L, it's the midline of trachea is line for dividing 1R and 1L. This is important because it's not always true for other lymph node station. So let's move on to number 2 lymph node station. It's called upper paratracheal nodes. It becomes a mediastinal node now. And upper margin is apex of lung and manubrial in the middle part manubrium notch. And the lower margin, I'm going to talk about in more detail for the lower margin. It's aortic arch for the left side. As I told you, division between number 1 and 2 is very important because it's dividing N2 and N3 node. But when you look at the CT scan here, it's really at the same section, as you may notice. So it's hard to know if it's 1R or 2R in the real world situation. So when I look at these kind of relatively recent paper, they made this separation using first rib. So first rib runs down obliquely. So when we use the first this bisecting line of the first rib, then it's really good to divide whether it's whether it's in the lower neck or whether it's in the mediastinum. So like anterior part of the bisecting line will be number 1, and posterior part of the bisecting line will be number 2. And then those bisecting line is drawn at the that bisects the 2 first rib. So I think it's a really good way to separate 1 and 2 lymph node station. And then let's move on to number 3 lymph node station. So it's 3A and 3P, you can see. 3A, as I told you, it's anterior portion of the major vessels. And the cutoff line is for the right side, it's SVC or brachiocephalic vein. And then for the left side, it's a common carotid artery. So even though it's around brachiocephalic vein in the left side, it's still 3A. But for the in the right side, if it's posterior than brachiocephalic vein, then it will be 2R. So that's the just difference between left and right side. But again, it's not too crucial, I guess, because it's just the same N2 nodes. So, and then 3P is very easy. So everything behind the trachea will be a 3P. And then one other important thing to mention is, so right and left, division of right and left for station number 2 is a left margin of the trachea. It's different from station number 1. Station number 1 was the midline of the trachea, but station number 2, it's left side. So that's one different thing you should note. And when we move on to station number 4, it's lower paratracheal nodes. So the upper margin of 4R will be brachiocephalic vein intersection to the azygos vein. So you may remember the name of azygos vein from the normal structure. So it's very important here. And for the left side, it starts at aortic arch to left main pulmonary artery. So left pulmonary artery is also important because, as I told you, 4 and 10, these two structure is dividing 4 and 10, which is 10 is N1 node, 4 is N2 node. So it's important structure to know. Okay, so again, similar to the number 2, the left and right division is done by the left border of trachea. And then division of number 2 and 4, I think it's not that important because it's both are all just N2 nodes, so it is not too important, but I think it's good to know. So right side, it's intersection of inferior margin of innominate vein is brachiocephalic vein with trachea. So as you may remember, the left side brachiocephalic vein intersect from SVC, which is in the right side, to the left side. So that intersect with the trachea. So that point is inferior margin of 2R. And for 2L, it's superior margin of aortic arch. It's much easier, much easier to know. And then you can see the lower margin here as well. The lower margin of lower paratracheal is, I'm emphasizing again, it's important because it's dividing 4 and 10. So right side it's azygos vein, left side is left pulmonary artery, superior margin of left pulmonary artery. And okay. And let's move on to the lymph node station number 5. So number 5, you can see its name is aortopulmonary or subaortic. So it's really stand for their location. So it's below the aortic arch. And between the 4L and 5, we can use the imaginary line here, like a blue dotted line here. It connects the posterior part of the ascending aorta and anterior part of descending aorta to divide 4L and 5 here. And then lower margin of 5 is left pulmonary artery. So above, below the left pulmonary artery, it will be a 4L in the midline, and it's 5. It is in the anterior part here. And number 6 is really close to aortic arch itself. You can see the aortic, and then upper and lower margin will be aortic arch itself. Upper and lower margin of aortic arch is defining the station number 6. And then we can move on to subcarinal nodes. And subcarinal nodes starts from carina. Carina is very easy location to distinguish. So it's trachea to main bronchus, dividing into 2 main bronchus. You can see the start of the subcarinal area here, and then below it, I call it subcarina. And subcarinal area ends at the for the left side, it's left lower lobar bronchus upper margin. For the right side, and bronchus intermedius lower margin. And after that, it becomes paraesophageal, number 8. So number 8 starts from the left lower lobar bronchus on the left side, and right bronchus intermedius on the right side, and all the way down to diaphragm. So it's near to esophagus, so we call it paraesophageal. And number 9 is far more lower part of a pulmonary system. That you can see the pulmonary ligament in the very lower part of the lung. You can see this ligament starts from the inferior pulmonary vein. You saw the, you may remember the pulmonary vein has superior and inferior part. So this pulmonary ligament connected to inferior pulmonary vein. So you can see the location of the station number 9. And then finally, we reach to the N1 nodes. Okay, so 10R and 10L. So 10R, division between 4R is azygos vein, lower margin. And then 10L is left pulmonary artery, upper margin. So those are hilar nodes, N1 nodes. And then after division of the lobar bronchus, between the lobar bronchus, there are interlobar node, interlobar space, and lymph node between that space, we call it interlobar nodes. So it's very easy to see the location of 10 and 11 with the coronal view. You can see 10 starts on the right, for the right side, 10 starts on the lower margin of azygos vein, and then ends at right upper lobar bronchus division. And for left side, it starts on the left pulmonary artery, and then ends at the left upper lobar bronchus branches. And the 11 is really interlobar space. We call it interlobar nodes. And then I guess this slide, I didn't include this one in the uploaded file, but you can see this file here. There are ambiguity for differentiation between 4 and 10, although it's really important because by definition, this part can be either 10R and 4R as well. However, in this paper, the authors say that if it's anterior to tracheal bifurcation, it is safe to say that it's mediastinal node, not hilar node, because it's surgical removal of this space is similarly difficult as mediastinal nodes. So we can call it, I would say, it is good to know the margin by definition for N10. And one other thing to know would be if it's ambiguous and it's in front of the tracheal bifurcation, then I would say it's safe to say that it's N2 node. All right, so I think I spent about maybe 50 minutes now. So I think we can do the next part in the second time. Do you before we have break? Do you have any question? For I explained the structures and the lymph node stations and the margin of the lymph node stations. Do you have any questions or comments at this point?
Hi, Dr. Abe. Hi, Professor Abe.
Hello.
Hi, I'm Hendra. Nice to meet you here.
Nice to see you again.
How do you differentiate between segmental lymph node or it is a lung nodule?
Segmental lymph node and lung nodule. Well, I think that's a very good question. But with the low resolution CT, as in our PET-CT scanner, although it's not too low, but I think sometimes it could be hard to differentiate if its lung nodule is really really close to segmental bronchus. I think it's pretty hard to know. However, I think it's if we look at the thin section CT scans, then I think we can see the margin between the segmental bronchus and the nodule. If we see any margin, any margin between the gap between the segmental bronchus, then I think it can say that it's it could be a lung nodule, and if it's not, then I think we should call it segmental lymph node metastasis. And also, I think the morphology should be more rounded for the metastatic nodule, I guess. But yes.
Thank you very much.
Okay. Okay. If you don't have a question, okay. So then let's take a break for 10 minutes. So let's start. Let's start at 10 minutes later than from now. Okay, thank you for. All right. So let's start the second part today. So in the second part, I'm going to talk about the lung cancer staging itself, and then some of the case reviews. And this 8th edition of TNM staging was effective from 2017. So I think all of you may familiar with this staging system. So, but I'm going to talk about it one more time because we don't memorize all of these. So you can see the T staging and from it's different from 7th edition. We have carcinoma in situ as TIS and minimally invasive adenocarcinoma as T1A MI. So it means that it's smaller than 3 centimeter and smaller with smaller part, smaller than 5 millimeter invasive component at histological analysis. And T1 basically defined as its tumor size is smaller than 3 centimeter and without any, without any invasion to the major major airways or vessels. And T2 indicates between 3 to 5 centimeter in longest axis, and it can be T2 without that size criteria if it involves main bronchus or viscera pleura or atelectasis or obstructive pneumonitis. So that's T2, and you can further divide it into T2A and T2B, and T3 means by size criteria is between 5 to 7 centimeter, or if it's invading chest wall or phrenic nerve or parietal pericardium or metastatic nodule in the same lobe as the primary tumor, then it's T3. With the size criteria, T4 is larger than 7 centimeter. If the tumor is larger than 7 centimeter, then it goes to T4, even though it doesn't touch any major structure. And even though it's smaller than that, if it's invade diaphragm, mediastinum, carina, trachea, heart, or great vessels, then it's T4. And also, if there's a nodule in the different ipsilateral lobe, then it's T4. So same side of the lung, but different lobe, then it's T4. And same side of the lung and same lobe, then it's T3. And it's different from M1A. M1A, if a metastatic nodule is in the contralateral lung, then it's M1A. So you can separate T3, T4, and M1A easily. And N category has not been changed from 7th edition of AJCC guideline. It's still a very powerful indicator of prognosis. You can see the survival rate decline drastically. So N1 is ipsilateral hilar nodes, and N2 is ipsilateral mediastinal or subcarnal nodes. And N3 is contralateral mediastinal or contralateral hilar for sure. And these are all one lymph node station 1, like it's outside of the mediastinum but lower neck area, and then it'll be N3. And M category is differentiated a little bit. So M1A indicates a tumor nodule in contralateral lung, or pleural pericardial nodules, or pleural malignant pleural or pericardial effusion are also M1A. And M1B is solitary single organ extrathoracic metastasis. So which means a single brain metastasis will be M1B, because It can be managed with a local therapy in the single metastatic space. That treatment will extend the survival rate, so it's differentiated from the M1C, which is multiple extrathoracic metastasis in one or multiple organs. So if there's two metastases in brain, then it will be a M1C. So this is the difference between 7th and 8th edition. So as I told you, TIST1A micro is a new category. And then MT1 and T2 size, T3 size category is slightly different according to the survival prognosis. And then one important thing is there was no size criteria for T4 previously, but in the 8th edition, if it's bigger than 7 centimeter, then it's automatically become T4. Even though there is no other invasion or anything. And so if a primary tumor is near with the carina, which is nearer than 2 centimeter, was previous T3, but is downstage to T2 because of the good prognosis. And also a telectasis of entire lung was designated for as T3 before, but now it's T2. And diaphragmatic invasion was T3, but it's upstage to T4 because it has very bad prognosis. And mediastinal pulmonary invasion, it's very hard to investigate. So it was T3, but it's not in the staging system in the recent 8th edition. And according to those T and N and M combination, we can make these staging starting from A1A to 4B here. I don't think we should memorize this. We can always use the table like this. And this is illustration of the T staging, as I explained. So T1 means smaller than 3 centimeter without any invasion to the main structure. T2 by size criteria will be 3 to 5 centimeter or involving main bronchus or telectasis, even if it's entire lung or telectasis, it could be T2. And then T3 will be the size criteria in the invasion of parietal pericardium like this in T4. So these are not we don't need all of this to be T4. We need only one to be T4 among these 4 categories. So it's I think it's very nice illustration. And end staging, it's not changed with previous one, but there's one proposed end descriptor based on some clinical studies. So it divides single and multiple N1 and single and multiple N2, and then skip metastasis in N2. So these descriptor may stratify the prognosis of patient further, but not in the main guideline yet. Maybe it could be added to the next edition. So right now we are using this simple and staging system. So you'll know what it is. And sometimes it's kind of confusing to uh, lymph node station to the end staging. So it's a very useful table to know that. So for the 10 to 14, it's very easy. These are for the right lung. These are N1 nodes, and N2 nodes. Like 2 or 4, it's easy because it's left and right side. But 3A and 3P, it's kind of hard to separate. But you can use the midline of trachea to differentiate 3A and ipsilateral and contralateral mediastinal nodes for 3A. And interesting thing is 3P is N2 node for the right lung cancer, but 3P will be the N3 nodes, like that means contralateral mediastinal nodes for the left lung. If you look at the CT scan, then you'll know why. And this, but that is one interesting thing. And subcarnal nodes are always N2 nodes. Subcarnal nodes are always N2 node for right lung or left lung as well. However, 8, we can separate 8 lymph node 8 station into N2 or N3 based on the midline of the esophagus. Okay, so that's it for the N staging. And then for the M staging, I already explained, but metastatic nodule in the contralateral lung will be M1A, and pleural or pericardial or metastasis will be nodules or effusion will M1A as well. But if it goes outside of the thorax, then it could be M1B or M1C based on the number of the metastases. And then how about the role of the FDG PET CT scan in staging? So we all know that FDG PET scans are very effective in management of lung cancer patients. But what are the like conclusive effectiveness? Those conclusive statements are in the NCCN guidelines. Can be summarized as this. I look for, found for all the mention with PET. So I summarize this like this. So first thing is when we characterize an indeterminate solid nodule, we can use FDG PET if it's bigger than 8 millimeter. And also if it's bigger than 6 millimeter for part solid nodule, we can use FDG PET CT scan. So the size criteria is different between solid and part solid nodule. I will explain why in the following slides. And most important thing is FDG PET CT scan is always useful for staging of non-small cell lung cancer in all stage 1 to 4. So it's recommended for the initial staging in NCCN guidelines. And it is not warranted in the routine surveillance after all treatment is done and patients are in no evidence of disease status, then it is not, FDG PET CT scan is not recommended. However, if there is suspected recurrence according to other imaging analysis or blood results, then we can consider FDG PET scan. And also, if the disease is confirmed, then we can use FDG PET scan, recurrent disease confirmed. And also, FDG PET CT scan is very useful for delineation of the radiotherapy target. So it's superior than CT or MRI. So it is recommended for the patient who will receive radiotherapy. So these are the conclusive benefit of FDG PET CT scan. And also there are multiple other benefit of FDG PET CT scan, according to many papers from like nuclear medicine field and radiology fields. You may all know that we can obtain many parameters from FDG PET CT scan, including SUV max, peak, mean, MTV, and TLG, and even texture features these days. And it is well known actually that SUV max has prognostic value. So higher SUV max can predict worse prognosis in this meta-analysis performed in 2010, like 10 years ago. And also 5 years ago, me and Professor Park and her colleagues in nuclear medicine performed the meta-analysis with the MTV and TLG as well. We found that these all three parameters are predictive of event-free survival and overall survival in this meta-analysis. However, so FDG PET parameters are very prognostic. So I think it can be used for patient stratification, maybe included in the TNM staging as well, but it's not included yet. That's because the normalization of this parameter between the scanner and reconstruction methods and measuring methods is kind of hard. So that's one thing. And then I guess it will take time, even though it's very effective for prognosis stratification. But I hope it could be included in the staging system. All right, so nextly, I'm going to talk about the benefit in the staging of like a specific benefit in staging using FDG PET CT scans. So for the long nodule description, so we can say it's solid nodule or ground glass nodule or part solid nodule or subsolid nodule based on CT finding. And solid nodule, it's very easy because all just nodule that obscure the normal lung structure, then it's solid nodule. But its malignancy rate is very low, relatively low, because there are a lot of like calcified, benign, non-specific solid nodules there. However, if we see the ground glass nodule, which means its focal nodular area of increased lung attenuation, that can obscure lung parenchymal structure. That can be observed. That does not obstruct the normal lung parenchyma. So like in this figure, you can see the increased intensity, nodular increased intensity, and you can also see the pulmonary vessels behind it. So we call it pure ground glass nodule. And its malignancy rate is higher than solid nodule, 18%. Because adenocarcinoma can start as like this structure because it's growing lepidically. Lepidic means these cancer cell like crawl across according to the uh, like airway. So it doesn't make a huge mess first, but it just make this kind of a ground glass nodule. And then there are part solid nodule, part solid ground glass nodule. This means it has two parts in the one nodule. One ground glass ground glass opacity, ground glass nodule in the background, and in the middle you see the solid part in the middle. Then it goes, its malignancy rate goes very high. So it's very typical manifestation of the adenocarcinoma. And subsolid nodule is subsolid nodule means just combining these two. If you're not convinced that it's GGN or part solid, then we can just it can just say it's subsolid nodule. So its malignancy rate is somewhere between the pure GGN and part solid GGN. So in this case, it's a serial follow of one nodule. It started as a GGN like this, and it became part solid nodule like this on the right side, and it was confirmed as adenocarcinoma. So this is why the cutoff for recommendation of FDG PET-CT scan for solid nodule and then subsolid nodule. So for solid nodule, its malignancy rate is kind of low. So FDG PET-CT scan can be considered if it's larger than 8 millimeter. However, if it's subsolid nodule, then even though it's only 6 millimeter size, but if its solid part is larger than 6 millimeter, then we can consider PET-CT scan because its malignancy rate is higher than solid nodule. However, it's recommended. However, it's not very useful actually. FDG PET-CT scan is not very useful to differentiate the malignancy and then benign lesion of this kind of subsolid nodule because it's even though it's malignant cancer, the cell population is kind of low. So FDG uptake is not very high. So as you can see in this case, although we can see the ground glass nodule here, pure ground glass nodule here, and there is no significant FDG uptake, but it was adenocarcinoma in situ. And also pure GGN here. There's a little bit of FDG PET uptake, faint uptake here, and it was the T1A MI. So it's kind of hard to differentiate if it's malignant or not with these subsolid nodules. So that's for the nodule classification, and let's move on to some case review. Okay, let's look at this. So these cases are from Seoul National University. So this, when we look at the MIP image, can anyone tell the finding of this MIP image? I think it's too easy to to interpret this MIP image. So I'll just explain. So you can see the two focal uptake in the upper lung area. And other than that, nothing looks like malignant. There's a arthritic uptake in the right shoulder, and there are some like extravasation of the tracer in the left hand area, and some uptakes in the abdominal space, probably like normal intestinal uptake, and also the stomach uptakes looking physiologic. So let me move on to the transsexual image. You can see the arthritic uptake in the right shoulder and two focal nodular uptake in the both upper lung area, but we don't see any suspicious nodule with increased FDG uptake in the mediastinum or hilar area. And otherwise, there's no evidence of metastasis, and you should look carefully for the adrenal gland as well, in liver, maybe kidney as well, but we don't see any abnormality. And when we look at the CT window of the PET CT scan, so you can see the two, so larger nodule here. So based on this CT scan, it's hard to say if it's a solid or subsolid or like pure. If it's not pure GGN, but it could be solid or part solid, and left upper lung as well. So we can say that it's right upper lung for sure, because you can see the major fissure behind it. And this major fissure is actually retracted by this nodule. So, and also there's a increased FDG uptake in both nodule. So indicates that these are malignant lesion. And also there is another finding in this chest CT. Anyone can tell the another finding on this CT scan? Can move one by one like this. Yeah, that's true. You can see the emphysema. This an emphysematous lung this patient has. Yeah, you can say on the oh, okay, that's correct. Other GGN in the right upper lobe. Yeah, so you can see the GGN here. So, but without any uptake here. And then we can clearly see the lesion in the CT scan. So it's a very unique case because this patient has 3 different nodule as that we learned. So here is pure GGN. And then left upper lobe, it's part solid. So GGN in the surround, and the middle part is solid. So it's part solid. And then this nodule, we can say it's solid nodule. So all of that, so these two are definitely lung cancer. because these are solid or part solid and spiculated and has increased FDG uptake. But this GGN might be just a benign lesion because it's small and just GGN and without any FDG uptake. So we can just report that finding. And then FDG, the important thing for FDG PET scan, we can say that the FDG uptake for these lesions, and more importantly, we should say that there is no hypermetabolic lymph nodes or metastatic lesion in other part of the body. So our report was like multifocal lung cancer. This report is so we don't think it's lung cancer with lung metastasis, because metastatic lung nodule is always solid nodule with very round and small. If it's like GGN or subsolid, then it should be primary lung cancer, not metastasis. So we call it multifocal lung cancer. And although this patient has multifocal lung cancer, but the staging itself is very low, actually. So if it's a metastatic lesion, then it should be contralateral metastasis. So it should be M1A, but all of those are primary, so it was not, the staging was not too high. And then it was confirmed to be adenocarcinoma after the bilateral upper lobectomy. So the GGN without FDG uptake was also adenocarcinoma. And for other T staging, FDG PET CT scan was reported to be very good for this type of metastasis. So when you look at the CT scan here, you can see the thick lining in the periphery of the lung. So what do you think it is, this thick lining in the periphery of lung? Yes, correct. And also plus, so this thickening is inside of the lung parenchyma, not pleura. Yeah, there is pleural metastasis for sure. Yes, that's correct. So as I explained, there are secondary pulmonary lobule in the periphery of the lung, but that lobular septum is not seen normally. But so you don't see any thickening in the left lung, but in the right lung you can see the lining in the periphery of lung. So it's abnormal. So we call it interlobular septal thickening, and it could be lymphangitic metastasis. Yes. And lymphangitis with this septal thickening and then diffuse FDG uptake surrounding the periphery of lung, we can call it as lymphangitic metastasis. And it is reported to be the diagnostic performance of FDG PET CT scan is very high in the previous paper. Right, and then this is next case. And in the MIP scan, we can see the focal uptake in the right lung and focal uptake in the neck area. Otherwise, I don't see any abnormality. You can see the focal uptake in the vocal cord area, but not really asymmetric. A little bit asymmetric, but not very um, apparent. So, and then you can see the nodule with prominent FDG uptake, but we don't see any suspicious mediastinum or hilar lymph node enlargement or uptake. When we look at the CT chest lung image, and there's a huge nodule with intense FDG uptake, and there's some other calcified nodule without any FDG uptake. So these solid calcified nodules. So this is when we look at the scan here, you can see the calcification without any FDG uptake here and there. So we can say that these are not metastasis because it's solid and calcified and there is no FDG uptake. So we can say that it's a benign nodule safely. So interpretation will be the hypermetabolic nodule in the right upper lung and vocal cord uptake. It could be malignant or physiological uptake, and other calcified nodules will be benign nodule because it's solid and no FDG uptake. So, and the biopsy was done, and it was lung cancer, and vocal cord cancer was confirmed as well. So it's not very typical finding for the vocal cord cancer, but I think we need to say that there is something suspicious, even if the probability is low. Okay, we have one question here, two questions actually. Is there any recommended SUV cutoff? Let's see. Yeah, that's actually there is no cutoff. So in the early time when FDG PET was introduced, we call it like SUV max of 2 or 2.5 as a cutoff, but that varies a lot. So sometimes inflammatory lesion could have very high FDG uptake, and when we look at the subsolid nodules, then in the so has a very low FGB uptake, so there is no really good cutoff for that. Bayesian malignancy calculator model example to report probability. To be honest, I'm aware of these type of calculators. I don't know. How about your experience with this calculator? Does it work well? Which parameters are included for this calculators? Maybe you can comment on this chat thing. And okay, yes, vocal cord uptake at anterior aspect is unusual. Yeah, maybe like lateral medial or lateral part could be physiological, but anterior part maybe it's unusual for the vocal cord uptake. To check vocal cord when mild uptake there. Yeah, I would say based on the comment from Dr. Wichana, so if it's suspicious, it is suspicious. If we can see that in the unilaterally or like anterior part, or maybe if there is some kind of thickening or nodular structure, then I think we should comment on this. And even though there's mild and symmetric and not suspicious at all, I think it's always safe to mention in the interpretive finding part, and then say that it more likely benign, something like that. Right. So next case, it's this huge tumor is obstructing lobar bronchus here, and FDG PET CT scan. CT scan is nice for this atelectasis, as you all know. And based on CT scan, it's hard to say where the tumor margin is, but in FDG PET CT scan, you can safely say that tumor margin is here because of the drastic difference of the FDG uptake. This is particularly beneficial for the RT radiotherapy planning. And also there is lower paratracheal lymph node metastasis, suspicious metastasis as well. And for NM staging, FDG PET CT scan is useful, particularly useful. So T staging, FDG PET CT scan is not very useful because because of the lower spatial resolution. But NM staging is I think it's very useful for this staging. So based on literature, CT or MR has varying performance for sensitivity of 50 to 60 and specificity of 70 to 80. And also FDG PET CT scan has a very wide range of performance according to the studies. Sensitivity of 58 to 94 and specificity of 76 to 96. So it's kind of hard to tell how accurate it is, but I think it's better than CT scans. And also the negative predictive value in T1 and T2 disease was very high for mediastinal metastasis. And I found this one meta-analysis published in 2011 for determination of the mediastinal lymph node metastasis. The pooled weighted sensitivity was 73% and pooled weighted specificity was 92%, which is not too bad. And for M staging, it's really good actually. So in this meta-analysis, sensitivity was 96% and specificity was 96%. So it's FDG PET CT scan is a modality of choice for evaluation of metastasis in lung cancer. So when you look at this case, you can see the primary tumor very well, and N1 lymph node, N2 lymph node metastasis, and N3 node metastasis in one MIP image. And also for M staging is very useful. You can see the primary tumor here and the telectatic lung here, and also the focal uptake in the left adrenal gland is definitely, you can say it's consistent with the left adrenal gland metastasis. And again, pleural metastasis can be well observed in FDG PET CT scan. Even particularly, we can see the general appearance of the pleural metastasis in the MIP image as well. However, for the brain metastasis, as you all know, it's kind of hard to tell with the scan itself because normal brain uptake is quite high. So for evaluation of brain metastasis, the brain MRI is much useful for sure. You can see a clear sign. But bone metastasis is always useful with FDG PET scan like this. And extrathoracic lymph node metastasis can be well observed in the FDG PET CT scans as well. So we have some comments here, I think. All right. Okay. Yeah, I think I don't think it's routine practice in Korea, but I think if that works pretty well based on your experience, then it could be a good practice after some more validation. Thank you for your comment. And next case, I have a few cases, but I don't think we have to go over all of these. These are just these are all cases from Seoul National University with some lymph node and like distant metastasis. So nothing very exciting, but we can see this one case here. So it's really typical right lung cancer with lymph node metastasis. So you can see the kind of very disseminated primary lung cancer in the right lung, and then you can see the enlarged node with increased FDG uptake in the 4R space and a little bit smaller node in the 2R space, but no other lymph nodes in the station number 1. And there is another nodes in the subcarnal area, in hilar or septal or interlobular, and no other metastatic lesion can be seen. This, and when you look at the chest lung field, lung window, you see disseminated lung cancer. It's behind the major fissure, so it's right lower lobe lung cancer with multiple mediastinal and hilar lymph node metastasis. So there is some enlarged lymph nodes in the 2R and 4R and subcarina and hilar that is consistent with the suggestive of the metastasis. So we can interpret as consolidative mass in the right lower lobe with increased FDG uptake and increased multiple lymph node enlargement with increased FDG uptake in 2, 4R, and 7 and 10R area. 10, it could be 11 or 12, but not really important, I think. And other contralateral hilar area, there is mild uptake, but it's not enlarged. So we don't think it's N3 node. And so conclusion will be the right lower lobe lung cancer with N2 lymph node metastasis, and there is no evidence of distant metastasis. So I think those other cases are similar. So, and our time is up now. So I'm going to finalize my lecture today. So I would say those normal structures when staging system, we can always look back and memorize again. So an important thing is FDG PET-CT scan is like officially recommended for staging in all stage of non-small cell lung cancer, and it's particularly helpful in NM staging. And it's very good to know how we separate lymph node station between 1 and 2. It was a bisecting line of first rib, and 4 and 10. It was right side. It was isogous vein, and 10 was pulmonary artery. Or I'm forgetting already, but you can see it in the from this material at all time. And also in the literature, we have good evidence that FDG PET-CT parameters have good prognostic value in non-small cell lung cancer. Hopefully it could be integrated in the staging system, but the normalization and the false positive findings could be the pitfall of these parameters. Right, that's I will. With that, I'll end my lecture today. So do you have any questions or comments at this last minute? Okay, thank you. Good to see you again. So is there any correlation between the primary tumor and the genetic mutation? You mean the FDG uptake and genetic mutation? Yeah, there are several papers out there. So not memorizing all of those results, but I think EGFR mutation is related with high FDG uptake, but KRAS mutation was not associated. And then some other heterogeneity features of genetic, like in genetic mutations. I think it's higher heterogeneity is associated with higher FDG uptake, something like that. So there are one paper I published recently, and it was about the association of the tumor heterogeneity, which was obtained from genetic analysis and FDG PET analysis. There was association, and those are independently prognostic. So these field, like radiogenomic analysis field, is growing rapidly. I think it's those fields have a great promise for the better patient stratification and better management of those lung cancer patients. And I think it's, and there are also many publicly available database, both imaging and genetic analysis. So if you are interested in and you can find the database according. You can refer to if those references are in my recent published paper, so you can look at it. It was published in EJNM MI research, so you can look at it. All right, so I think that's all for today, and thank you all for listening carefully to my lecture and joining to the lecture, and thank you. See you next time.